Rheumatology Test 3, we are getting a 24-year-old man. And progressive pain, low backache and buttock pain for last many months. Pain is severe in the morning hours, fades as the day progresses. Pain is relieved with warm shower or over-the-counter analgesic. Associated symptom include stiffness, but the patient has no fever, no GI symptoms. No trauma, no illness, vitals normal, and there is a limited range of movement in the lumbar spine. Muscle strength is normal, deep tendon reflexes are +2. X-ray finding in the image is given below. Oh yes. Now these patients are the greatest risk of developing what problem? Answer is anterior uveitis. Well, there are certain points I have written here also. In fact, this is a case of ankylosing spondylitis. Point in favor is young age, 24 year. Low back ache, limited range of lumbar spine movement. They're all going in favor of so-called ankylosing spondylitis. But we cannot ignore this word, woman. Why I have written this word especially? This one point which could have distracted your mind, because in our mind we know that ankylosing spondylitis is much more common in males as compared to female. That is true. But do not forget that this disease can occur in female also, although uncommonly. This is the point, the highlight of this question. Okay, now things are very clear. Can it be coarctation? No hypertension, ruled out. Episcleritis, this is seen in rheumatoid arthritis. Now come the question to you. Write down the answer in your copy. Which eye abnormality occur in ankylosing spondylitis? That means what pathology occurs, which is classical of ankylosing spondylitis. Write down the answer in your copy. Answer is uveitis. Ischemic optic neuropathy, this occurs in giant cell arthritis, so-called cranial arthritis. Obstructive lung disease is in ankylosing spondylitis, we get restrictive lung disease. We don't get obstructive lung disease. So lovely summary is given here, well, but we'll discuss in great detail also. The correct answer is anterior uveitis. Okay. So let's discuss more about ankylosing spondylitis. It's an insidious onset below the age of 40 or 45 years. Symptom more than 3 months. It has to be, but in RA it should be more than how much time? Write down the answer. In RA the symptom should be more than how many time? What time? 6 weeks. Here we have 3 months. Relief with exercise but not with rest. This is same with RA also. This is the feature of all inflammatory arthritis. Nocturnal pain is a feature. So we are getting that in this case we are getting sacroiliitis. It's the earliest joint to involve. That's why they come with the low backache. Reduced chest expansion and reduced spinal mobility. Reduced spinal mobility. And again a question for you. Tell me what clinical test we do to see for the reduced spinal mobility. Write down the answer in your copy. Which the clinical test we do? Answer is SCOBA test. Enthesis, tenderness at the attachment of tendon to bone. Now again write down the answer. Which 3 tendons are most important which can lead to enthesis? Write down the answer. Which tendon are most commonly involved in ankylosing spondylitis? 3, very very important. Tendoachillitis, plantar fascia, which can lead to plantar fasciitis, costochondritis. They are the three important tendons which are usually, so they can lead to heel pain, ankle pain, heel pain, and the pain chest. Dactylitis, swelling of finger and toes, and uveitis. In fact, uveitis is the most common. It's the most common extra-articular manifestation. Manifestation of ankylosing spondylitis. Complication, osteoporosis, and that can lead to vertebral fracture. AR and quad equina, this all because the vertebra can get fracture, and that can lead to quad equina. Now again a question for you, write down the answer in your copy. Those patients who have quad equina, they classically they have some sensory disturbance. What is that area known as? Okay, what is that area known as where the sensory disturbance occur in quad equina? Answer is saddle. Saddle shape. Okay. Elevated ESR and CRP, they are the simply non-specific, but they are marker of inflammation. Actually, B27 association is a very, very important point that you don't forget. X-ray of the sacroiliac joint is the first to be done, but it's the most accurate. Most accurate test to diagnose AS is MRI of spine. Now, this was the basic concept that we learned. The patient in this question has low backache, stiffness that improve with activity, okay, and warm shower, non-steroidal agent suggestive of inflammatory backup. Here the reduced spinal range of movement is very, very important point, with one point which really indicate that we are dealing with ankylosing spondylitis. X-ray shows arthritis and erosive involving sacroiliac joint. If you look into the X-ray once again, you can see the sacroiliac joint is erosion are seen. And this is what we diagnostic of one of the very important diagnostic finding for a case of ankylosing spondylitis, sacroiliac joint. The incidence is highest in the age of 20 to 30 years, very, very important. ES never manifests after first time manifestation after 45 years. Then it is not a case of ankylosing spondylitis. And they have a strong association with HLA-B27. Anterior uveitis is the most common extra-articular manifestation. It can occur in as high as 25 to 40%. It's fairly high. And do remember that these belong to ankylosing spondylitis belong to seronegative arthritis. Seronegative arthritis. This uveitis can occur in most cases of any seronegative arthritis. Okay, now one more question for you. Write down the answer in your copy quickly. What are the other example of seronegative arthritis other than ankylosing spondylitis? Other example of seronegative arthritis. And in the meantime, just to inform you, seronegative means they are rheumatoid factor is negative. That's the meaning of seronegative arthritis. So the other example of seronegative arthritis are psoriatic arthritis, Rhesus disease, also called reactive arthritis. Arthritis occurring in inflammatory bowel disease like ulcerative colitis and Crohn's disease. They are some of the other example of seronegative arthritis. In all these cases, uveitis can occur. Now, coarctation of aorta, aortic coarctation is associated with aortic valve, typically AR, Ankylosing spondylitis is associated with aortic valve disease. Okay, aortic AR is most common. They can have MVP also. They can have MR also. But coarctation is associated with Turner syndrome, not with ankylosing spondylitis. Episcleritis is an inflammation in the white of eye without involvement of the uveal tract, and this is a feature of rheumatoid arthritis. Okay, and it may be there in inflammatory bowel disease also, but definitely it is very uncommon to be associated with the ankylosing spondylitis. It's not. It's more of a feature of rheumatoid arthritis. In rheumatoid arthritis, there can be scleritis also. Scleritis also. Now come the gold medal question is there. Tell me the patient has involvement of sclera in a patient of rheumatoid arthritis, scleritis, episcleritis, that sclera is involved. Now this patient can have which dangerous complication of the eye? Write down the answer in the copy. The question is, we have a patient of RA whose sclera is involved. It can lead to which problem? Quickly write down. It can lead to rupture of the eyeball. Rupture of eyeball. Because of scleromalacia. There can be scleromalacia. That can lead to rupture of the eyeball. Question number 2. We are getting a 23-year-old lady, low backache, 23-year lady, low back pain and stiffness. Last few years. Worsened during the recent week, relief of pain with physical activity over the counter of ibuprofen, morning stiffness that lasts for an hour, but no rash, no ocular symptom, urine symptom or diarrhea. And as far as she's afebrile, reduced forward flexion of lumbar spine, tenderness over the lumbosacral area, remainder is normal. Most likely to establish diagnosis, X-ray of this sacroiliac joint. Well, point to be noted, this can occur in female also, although it's rare. That's one point which can distract in this patient, because we are getting a lady patient with ankylosing spondylitis. Okay, so let's look into other option also. This is done in SLE. ESR is a non-specific. It can be raised in so many conditions. HLA is seen in AS, but X-ray is more important. This is a gold medal line. I'm sure. In fact, it is this reason I took this question. Of the two reasons why I chose this question. One is to make you clear that this can occur in female. But even more than that is this, that although HLA, B27 and X-ray both are equally contender for the answer, right answer. But given the board, this is the more important. This is the gold medal line is there. Again, reminding you, in the examiner never say choose the right answer. See, they choose the most appropriate answer. This is also right. This also right. But more correct is X-ray. Don't forget. Nuclear scan is done in mainly for bone metastasis, not for the ankylosing spondylitis. This is a summary of the question which I wanted to highlight, but the main highlight was HLA. Now things are very, very easy for me. So regarding ankylosing spondylitis, I have given the same thing which I gave you in the previous question also. Anybody want to read the same? You can stop the video later on. You can see that there is no point in repetition. So now let's come to the main question, which is the need of discussion. So as I told you, there are typical features of ankylosing spondylitis: chronic progressive back pain and stiffness, pain relief with activity. That is the classical feature of ankylosing spondylitis. Lumbosacral tenderness and reduced spinal range of movement, so-called Schober test, is a classical feature. 20 to 30 years is the age and ratio male female 2:1. but more than 3 months of stiffness is there. Some of the books have given the more, maybe 4:1 is to also. So different literature have given ratio, but definitely it is more than in male as compared to female. Of course, the ratio differ in some of the literature. So we are a young patient with characteristic inflammatory back pain. X-ray of the pelvis should be done to rule out sacroiliitis. Of course, again, MRI is a better option. If X-ray and MRI is given, which is the best, MRI is the best. Otherwise, sacroiliac joint is the first is to do the X-ray to rule out any abnormality. But X-ray may be negative in early stage. That's why MRI can confirm even such cases. That's why I've been saying MRI is the best investigation to be done for ECA for us, ankylosing spondylitis. Later on in the advanced stages, you get bamboo spine. Why? This is the vertebra. This is the vertebra. They are the intervertebral ligament. These intervertebral ligament, they get calcified. So when we take X-ray, you get bamboo spine like this. You can see bamboo spine. Okay. Or our fusion. Bamboo spine is a late feature. There can be marginal this syndesmoside, and there is fusion of sacroiliac joint, and there is generalized osteopenia, other feature. But usually in the exam they talk more about bamboo spine. The beautiful picture is there in front of you. Strong association with HLA-B27, the point I mentioned in the discussion also. Let's focus, let's talk in more detail. 90% of patients with AS will have HLA-B27. That means it's not 100%. Now look into other side, but only 5% of the patient with HLA-B27 will have ankylosing spondylitis. Point to note it very carefully. So HLA is not specific. So testing is not necessary for diagnosis. It is usually done, but not absolute. If we are getting MRI finding, it is a strong indication. Well, skeletal changes are more essential to diagnose, including X-ray and MRI. Well, as I discussed, ANA, anti-nuclear antibodies, this is more common in SLE. Of course, this is seen in many other conditions also. And rheumatoid factor is elevated in rheumatoid arthritis, as ANA in SLE. But both can be abnormal in variety of other autoimmune disease, but not necessarily, but they are usually, ANA and rheumatoid factor are usually not there in AS. Point to be noted, there can be other condition like ANA. ANA can be there in scleroderma. It can be there in chronic active hepatitis also. Rheumatoid factor may be present in Sjogren syndrome. RA does not involve spine, except cervical spine. Very, very important question. That's why in RA, low backache is never a feature. ESR, CRP, they are a feature of acute phase reactant, acute phase marker. So they can occur raised in any of the acute infection or inflammation. So they have low specificity in diagnosis. Nuclear scan, they are not recommended. This is only for osteomyelitis, suspected fracture and neoplasm or metastasis. Question number 3. We are getting a 52-year-old man. Long history of joint pains. Pain and stiffness in the small joint of his hand. Worse in the morning. Can last for several hours. Digital swelling is there and picture is shown. Well, most likely diagnosis is psoriatic arthritis. Again, I just give you summary before I really go into detail. Hand joints involved, sausage digit are seen. There are the 2 points favoring psoriasis, but the point going against It is more in female, but our patient is a male. But again, it can occur in males also. Crystalline arthritis, gout, pseudo-gout, Milwaukee syndrome, they all together have different type of joint involvement. Now, I have a question for you. Tell me which joint are most commonly involved in gout, pseudo-gout and Milwaukee's shoulder. Write down the answer. Which joints are most commonly involved in these three conditions? So-called crystal arthropathy. Quickly write down. This is great toe. This is knee. This is shoulder. Don't forget. Dermatopolymyositis, proximal muscle weakness is a feature, and there are certain skin signs also there. Neuropathic arthropathy occurs in diabetes, sensory loss, so-called Charcot joints. And OAA is knee joint. So lovely summary squeeze in this, and if you can look into, none of them is including the fingers. Otherwise also rule out, none of them. Here the hand joints are shown. Hand joints are not involved in any other condition. So now the question discussion is much easier with this background. So we talk about psoriatic arthritis in more detail. The clinical feature of psoriatic arthritis, distal DIP is involved. Why it is so important to write separately? Hand joint, DIP involved. What does it really want to signify? Write down the answer in a copy. DIP involved. Yes, it rules out rheumatoid arthritis. In RA, DIP is not involved. Hand joint are involved in RA also, but DIP classically not involved. Asymmetrical oligoarthritis. Symmetrical polyarthritis similar to rheumatoid arthritis. This is gold medal line. So we have one entity, one type of psoriatic arthritis, which has a type of symmetrical arthritis what we see in RA. Okay, just remember. So now come the question, you are getting a lady who has come with the bilateral the joint pains. One thing is DIP involved is pakka. It's not a case of RA. Second, much easier in psoriatic, skin lesions are usually there. Now come the question to you. Tell me what is the characteristic of skin lesion that by at a glance you can say this is, what is the feature, what are the color, what they say? Yes, the answer is they are silvery scale. That's you are usually there, and nail involvement is there in psoriasis. Okay, psoriasis with a classical feature that we see in severe. These are not seen in rheumatoid arthritis. Arthritis mutilans, deformity and destructive arthritis occurs. This is a very severe type. Again, a question for you. Tell me, if you do X-ray of a case of arthritis mutilans, what is the X-ray finding you will be getting in these patients? Write down the answer quickly. What type of X-ray finding you will be getting in these patients? Well, the answer is pencil in cup appearance. What we get in arthritis mutilans, and there can be spondyloarthritis and sacroiliitis or spondylitis can be there, which is a feature of seronegative arthritis. Now, as I told you, soft tissue and nail involvement, enthesis, inflammation at the site of tendon. The site of attachment of tendon to bone is painful. Dactylitis, sausage digit of toe and finger. Okay, sausage digit. It's also seen in Rhetta's disease. Nail pitting and onycholysis can be there. Swelling of hand and feet with pitting edema can be there in these patients. So there are so many additional features that we get in psoriasis. Now, skin lesion. Arthritis precedes skin lesion in 15% cases. Point to be noted. Only 15%, not a common thing. Of course, 85% skin lesion will be there. Skin lesions are present but not yet diagnosed in 15% of the patients. Well, in this patient, we are getting history consistent with psoriatic arthritis. And as I told you, now extra point. Psoriatic arthritis occur in only 5 to 30% of the patients who have psoriasis. Not every case skin lesion of psoriasis will have arthritis, only 5 to 30%, maximum up to one third. They can present with many different patterns, but the classical presentation is DIP. I mentioned you there are 5 type of presentation is there, but DIP presentation is the earlier, is a very classical feature that we get. But in the most advanced stage, what we get? Yes, arthritis mutilans. Morning stiffness is present as in all inflammatory arthritis. It is more than 60 minutes. And in non-inflammatory, it is less than 30 minutes. Deformity of finger, which can cause sausage digit, can be there, nail involvement are there. And now you can see the picture of sausage digit. You can see sausage digit. You can see this is what chicken sausage. It's sort of like a barrel shape, like this thing. Sausage dactylitis. You will not forget this picture. So our patient shows all the classical sign. You can see in the picture all the finger are swollen, especially left index finger. Many of the nodes you can say pitting and onycholysis. What is onycholysis? Separation of nail pad. And finally DIP are predominantly involved. All these, but we are seeing in this patient, at least we can see swelling finger, and we can see the nail picture finding are there, and that really suggests that we are dealing psoriasis, and none of the other option they fit anywhere near the psoriatic. So well demarcated silver lining are silver scales are seen in the dorsum of the hand. If you can revisit the question, you can see the silvery scale with DIP, golden line to remember. Silver scale plus DIP. This is psoriatic arthritis. If single whole question is squeezed in 2 words, silvery scale and DIP, psoriatic arthritis. Well, this question we already discussed. Crystalline arthropathy, nail changes do not occur, gout and pseudo gout. Moreover, cutaneous deposits are seen in monosodium urate crystal in chronic gout, but they are altogether different. They are not silvery scale. Moreover, the joint involvement is what I said, gout is great toe and pseudo gout knee, and maybe you may get to 5 soft tissue swelling in gout. They occur over the joint helix of the ear, and they may ulcerate, but they don't involve much of the fingers. And moreover, silvery scale is not a feature of gout. Dermatopyositis, they can have a Gottron papule, wireless plug over the metacarpophalangeal joint here. Okay, they look like psoriasis, but they tend to occur over the joint, not over the fingers. And moreover, psoriasis is the one disease which involves the whole body, especially in the extensor aspect. So we can see the scale not only over the hand, it can see in many other places also. Moreover, dermatomyositis does not have dactylitis or nail separation. Onycholysis is not seen. They have a muscle weakness is there. Classically, proximal muscle weakness occur. Neuropathic pain is Charcot joint, most commonly affect the lower limb, more in diabetes, but syphilis and alcoholism are the other causes. Syphilis used to be a very, very important cause 30, 40, 50 years back, but now syphilis as such is there. But because of the advent of good treatment, the chance of going into tertiary syphilis, this is a disease of the tertiary syphilis, which occur after decades of the syphilis. So now this is not seen very commonly. So now the common cause is diabetes. Peripheral neuropathy is believed to cause decreased proprioception, and that lead to trauma and eventual deformity. So proprioception is lost. Now I have a question for you. In the bedside, okay, bedside, we want to test proprioception. What test you would like to do? Look for the proprioception. Write down the answer. In a clinical bedside examination, you will use tuning fork. Tuning fork. Okay. Now tell me, now very simple question for you. For vibration sense, we use tuning fork. What is the frequency of the tuning fork that we use to look for vibration sense? Write down the answer in your copy. What is the frequency of the tuning fork? Answer is 128. 512 is for hearing, for the ear. 128 for vibration. This question done by 90% students commit mistake. So don't worry. Osteoarthritis often affect DIP, but it's a disease of the elderly person, and the activity worse with the activity and improve with the rest. In our patient, it is reverses there. So this cannot be OA. And dactylitis is not a feature because why? OA is a non-inflammatory arthritis. We are getting a 32-year-old lady who has come from Turkey to USA, and she come to you with, she has oral ulcer. She also have multiple painful sores on her oral mucosa that began few days back. She had similar lesion 3 months ago, healed without scarring. In addition, she was seen by ophthalmologist for blood vision, and anterior uveitis is there. She also have recurrent genital ulcer, and there is scarred hyperpigmented skin lesion, tender indurated leg areas. Diagnosis: Behcet syndrome. Well, why the answer? Why not others? 32-year-old lady migrated from Turkey. This very, very important point, because this disease is very common in Turkish ethnicity. So we have seen there are so many diseases which are especially involved in a particular area of the world or geography. So this, if you are getting this type of picture from a Turkey, you think about Behcet syndrome. Oral ulcer, anterior uveitis, recurrent genital ulcer. 1, 2, 3, 4. If you know these 4 words, this is the answer. Whole Behcet syndrome is squeezed in 4 words. Turkey. Recurrent oral ulcer, recurrent genital ulcer, and anterior uveitis. You are dealing with Behcet syndrome. Let's learn more. First and very, very important point. Behcet syndrome is a type of vasculitis. And what is special thing? It's the only disease by and large major where all types of blood vessels are involved. Can't afford to forget to show only this, that all types of blood vessels are involved, including you can see large vessel, medium vessel, small size vessel, everything is involved, and that is the classical feature of Behcet syndrome. Okay. Recurrent oral ulcers, you can see recurrent genital ulcers. This is anterior uveitis. Oral ulcers, genital ulcer, anterior uveitis. Skin lesion is erythema nodosum. There may be papillopustular lesion, but usually they talk about erythema nodosum. Now I have a question for you. Erythema nodosum is a very commonly asked question. It is seen in tuberculosis, streptococcal infection, etc., etc. Simple. Now tell me, erythema nodosum is seen in which blood malignancy? This is a gold medal getting question. In which blood malignancy we see asthmatism? Hairy cell leukemia. Okay. Pathology tests, again, very important. Even a small scratch can lead to intense inflammation. Okay, even you just a small scratch over the skin, it will lead to intense inflammatory response, so called pathology test is positive in this patient. So let's learn more about Behçet syndrome. So we have seen, so let's more young adults are more commonly Turkish, Middle Eastern or Asian descent. Out of this also, this is single most important. So recurrent painful oral abscess ulcer like in our patient, gentle ulcer like in our patient, uveitis in our patient, skin lesion, asthma nodosum like in our patient. These are the features that are there in our patient also. As I told you, these four are diagnostic of Behçet syndrome. They are prone to thrombosis also, superficial and deep thrombophlebitis. Pathology tests, as I told you, exaggerated skin ulceration with even minor trauma. Even do a needle stick. Okay, just you scratch with a needle, it will lead to intense inflammatory response, and you get biopsy, different types size blood vessel. It involves all types of blood vessel. The unique thing, rather it's the only disease by and large, major only disease which involve all types of blood vessel. So our patient has the Behçet syndrome, recurrent painful ulcer, gentle ulcer, uveitis, asthma nodosum. The point I mentioned to you, our patient has all the features what we have, so we are more likely that we are dealing with Behçet syndrome. Okay. So diagnosis is based on the clinical finding, and lab evaluation is primarily directed to rule out other findings. There is no okay, we rule out. You can do biopsy, but that may not be very essential to diagnose. But if you do it, you may get a non-specific vasculitis. But now come the gold medal question. In these patients, one antibodies may be there. Write down which antibodies may be there in these patients. First question. Second question, that antibody may be present in which other disease? Answer is anti-Saccharomyces. Saccharomyces cerevisiae antibody. What we write ASCA in short. And these antibodies are also there in inflammatory bowel disease, Crohn's disease more than the ulcerative colitis. They are also seen in Crohn's disease. And the extra thing, of course, treatment, we also use thalidomide. We use thalidomide in the treatment of this condition. This is a new drug. It was, we all know, this drug had lead to the worst side effect of any drug in the medical history, and it was given to pregnant lady. It lead to phacomelia. The limbs, so-called seal type of limbs. So it is absolutely contraindicated in pregnancy, but it has again come up. And now we are using in so many other diseases. Some of the other disease where we are using this drug is multiple myeloma. Okay. In multiple myeloma is a very, very important condition where we are using. We also use in lep, leprosy, lepra we use in leprosy also. Okay, so this, don't forget multiple myeloma. What about herpes simplex? Can cause oral and genital ulcer and uveitis. True, but they come as a vesicle which coalesce to form a lobe-shaped ulcer, and they occur at the same location. And eczema nodosum, recurrent ulcer, uveitis makes Behcet syndrome more likely, because eczema nodosum is not seen in herpes simplex. Reactive arthritis is a disease classically of young males. So there are certain features which can be there with Behcet syndrome, arthritis, uveitis, oral ulceration. But this reactive arthritis, it may occur due to acute gastroenteritis caused by Salmonella, Shigella, Yersinia. It may also occur due to genitourinary like chlamydia infection. Causes acute and subacute to chronic rather than episodic symptom. Episode, like in Behcet syndrome, episodic feature is there. Here is subacute and chronic, and this disease is more in males, much more in young males. They are the point in favor. Sarcoidosis is a systemic disease characterized by non-caseating granuloma, most commonly in lungs. It is associated with arthritis, uveitis, and erythema nodosum. It usually causes significant respiratory symptom. Recurrent urogenital and after ulcer are not typically seen in these patients. Okay. SLE is a multi-system disease. Malar rash, so-called butterfly rash over the face. Patient may have fever. Oral ulcers are common but typically painless, point to be noted. And genital ulcers are not the feature in this patient, and they have multiple other features are there. Question 5. A 56-year-old man, 56 men, pain and swelling in the right knee, synovial fluid obtained shows white blood cells 25,000 per ml with neutrophilic predominance, rhomboid crystal and weak positive birefringent under the polarized light. This is calcium pyrophosphate. So this is a case of pseudo gout. 56-year-old man, swelling in the right knee, rhomboid crystal with weak positive. This is a golden line to remember. Golden line. If you are getting this in the knee joint, in an elderly person, knee joint with the rhomboid crystal, this is pseudo gout. Golden line to remember. So let's talk a little bit more. Pseudo gout, so-called calcium pyrophosphate deposition disease, we call it CPPD. Accumulation of calcium pyrophosphate crystal in the synovial fluid. So that's why the right knee was swollen, effusion is there, and it can come as a mono or oligoarticular, maybe single joint or maybe one or two joints. Pain, joint swelling, edema, worm, that means a type of inflammatory arthritis. That's why when we did the synovial fluid aspiration, there were neutrophils predominance was the features. Pseudo gout and gout can be difficult to distinguish. Clinically, sometimes they are difficult. Why? Although it's of course, gout occurs in the age of 20 to 50 years. Pseudo gout usually occur above the age of 50 years. One is age differences there. It involves the great toe joint, and it involves the knee. but even gout can involve a knee joint. So that's why it may become a little bit difficult to diagnose. Knee joint is involved in more than 50% cases of pseudo gout, where the first metacarpopharyngeal joint is more typically involved in gout, the point I just mentioned to you. So in pseudo gout, synovial fluid will reveal increased WBC count with neutrophil predominance. Okay, and same thing we see in gout also. As far as cells are concerned, it's again neutrophil predominance with increased TLC count. But we get rhomboid shaped crystals is a diagnostic. And what type of crystals we get in gout? Write down the answer. What type of crystals, shape of crystal is there? Yeah, they are needle shaped crystals. The rhomboid shaped crystal, which you can see, look into this is the rhomboid shaped crystals. Okay, so they are positively birefringent. What is the meaning of positively birefringent? If you see under polarized light, that means you have to see under polarizing microscope. Color pattern is the opposite to that seen in gout. Okay, what CC crystal are blue when light is aligned to parallel, and yellow when they are aligned perpendicular. I'll show you this picture in the next question, but as of now, just remember, direct, they are positively birefringent. Even if you remember this much, more than enough. Nobody is going to ask you this, but it's for just I want to give you additional knowledge. But this positively birefringent rhomboid shaped crystal is the usual thing what is going to ask you in the exam. Okay. X-ray. Meniscal calcification is virtually one of the diagnostic features. Look into this. Calcification, meniscal calcification is one of the a classical picture you cannot afford that strongly indicates pseudo gout. Now let's look into other option. Calcium hydroxyapatite. This deposition of calcium hydroxyapatite in the tendon of shoulder joint. Rotator cuff tendon are most commonly involved. Okay, and this one disease also called as Milwaukee syndrome, also called Milwaukee shoulder. Calcium oxalate is a very common of renal calculi. It has nothing to do with the joint pains. Monosodium urate is a gout, okay, which causes soft tissue swelling. I'll be discussing more detail about gout in the coming questions. Cholesterol is the one which get deposited in the form of xanthoma. Okay, soft tissue xanthoma. They appear as yellow papule over the knee elbow tendon. In hyperlipidemia, definitely cholesterol deposition occur. Hyperlipidemia is the one indication. So definitely it is over the skin involvement is there. It is visible. Nothing to do with the joint pains. The golden line to remember, rhomboid shaped calcium pyrophosphate crystal is a diagnostic of pseudo gout. Positively birefringent under polarizing light, knee joint is involved in more than 50% cases. So dear friends, rhomboid crystal, positive birefringent knee joint. Don't forget, this is pseudo gout. We are getting a 62-year-old Caucasian man. Repeated episode of ankle arthritis, nodule near the right knee joint. Biopsy reveals many inflammatory cells and long crystals that are negatively birefringent. Long crystal negative birefringent is gout. Golden line to remember. This is the golden line to remember. Male patient, monosodium urate crystal are deposited. Point to note, it's not uric acid crystal, not at all, not uric acid. This is the most common wrong answer. It is monosodium urate crystal are deposited. Of course, they are made from uric acid. The crystal deposit, what we see is a needle shaped crystal are of monosodium urate, not uric acid. So we are getting 62-year-old man, repeated episode of ankle arthritis, nodule near knee, long crystal negative birefringent. But one thing is there, they did not mention about first toe or first joint, or you can say great toe joint. That is not ankle joint. Although the great toe joint is most commonly involved, but it may also involve ankle and knee also. This is how they can confuse. So we are talking about gout. Increased uric acid concentration is there. That lead to increased. Now this increased uric acid may be due to increased uric acid production or decreased uric acid excretion. So ultimately, they both will lead to hyperuricemia. But point to be noted, patient may develop gout without hyperuricemia also. It's not a prerequisite that uric acid level should be high. It may be low also. Now, uric acid salt, monosodium urate crystal are accumulated in the are there, and when the concentration goes very high, when the synovial fluid saturation is increases, they get precipitated. Okay, and they make crystals in the synovium and the cartilage also. Now, this monosodium crystal are taken by the neutrophils and they lead to free radical release, cytokine production and inflammatory response. So now you know that is the inflammation going on. Inflammation going on that lead to free radical, because the free radical cytokine and they all lead to a type of inflammation, and that lead to severe red joint, severely inflamed joint. Okay. Now one thing more. This joint, typically what we have, great toe joint, what we call as podagra. Write down podagra. I'll show you the picture also. Typically great toe joint is there. So now monosodium urate crystal, what I told you, will get deposited in the joint, can lead to arthritis. But it can even deposit in the skin also, what we call as tophi. So tophi are the soft that deposition of these monosodium urate crystal in this ear lobule, etc. They are deposit tophi. And typical gouty patient are 40 to 60-year-old obese male who are alcoholic. Usually alcoholic, not always. Usually single joint, but it may be multiple joint also, but usually single. Lower joint extremity are much more ankle, knee and great toe. 50% of the patient will have first metacarpophalangeal joint involvement, so-called great toe joint. It's the most common joint that we see, more than 50% cases. Now it comes present with severe acute onset, severe joint pain, warm edema and swelling. And it is extremely tender. These patients have grade 4 tenderness. Grade 4 tenderness. Now there are two questions. How do you do the grading of tenderness? Okay. Well, I'll tell you. Tenderness is the sign that a physician elicits. Simple. So suppose the patient has come to you with pain in the right knee, you touch it, patient says, do you have pain? He says, yes, I have pain. You touch, he has pain, grade 1. This is grade 1 tenderness. Now you touch the joint, he winches with pain. Grade 2 tenderness. Okay, grade 3 you touch, oh doctor, he withdraws. Grade 3 tenderness. Grade 4 you tend to don't touch doctor, don't touch. This is grade 4 tenderness. So grade 1 is you touch, pain, yes. Grade 2 grade 3 withdraws. Grade 4 won't let you touch. So now you can see what I told you in this grade 4 tenderness is there. So painful, excruciatingly painful is the grade 4. Now one more question. Tell me any other condition you know of where we get grade 4 tenderness. Write down the answer. Any other condition you know of where we get grade 4 tenderness? Yes, answer is septic arthritis. Second is arthritis occurring in acute rheumatic fever. So septic arthritis and arthritis occurring in acute rheumatic fever, there are two important conditions where we get grade 4 tenderness. So we come back. So left untreated, they tend to get resolved within few weeks, but they definitely need treatment. You can diagnose synovial fluid analysis, the different diagnosis by synovial fluid, where we get lot of WBCs and neutrophilic predominance. This we saw in pseudo gout also. It's acute inflammation. But you can be seen in the polarized light. What we have, needle-shaped crystal which are negatively birefringent. So they are reverse. When the crystal are aligned parallel, they appear yellow. When they align perpendicular, they appear blue. Now look into, first is podagra. Podagra is the grade 4 tenderness. This just see, grade toe joint is involved, can't forget. And this is the uric acid stone. Okay, and uric acid crystals are there, which we can see in urine. And tophi, I was talking to you, soft tissue deposition tophi are there, which are deposition of monosodium in the subcutaneous tissues. And finally, this is there negatively birefringent. Look, we are getting two colors. One is blue, and blue are like, you can see, blue are like this. And the red color I can draw like this. That's a better idea. If I, yeah, red are like this. Blue are like this. Blue color. Oh, green. Never mind, blue color. So now you can see the arrangement is different. So now you again go back to the literature where I was talking to you. Now read it. Crystals are aligned parallel. They appear as yellow. When perpendicular, they appear blue. Perpendicular blue. Okay, light is coming like this, and parallel they are yellow, or you can see this is light is coming like this. If they are parallel, it is yellow, and if they are perpendicular, they are blue. This is negatively birefringent. So finally we get tophius gout, and in X-ray, if you look, is a type of erosive arthritis. It leads to destruction of the joint. Look into this great toe joint. It is totally destroyed. Okay, you can see. This is called rat bite sign. It looks that rat has bitten this joint and removed this particular area has been eaten away. Also known as Martel sign or G sign. That means the area has been eroded by the long-standing monosodium urate. So we are clear about it, why the answer is gout or monosodium urate. Calcium oxalate, they are in renal calculi. Uric acid hyperuricemia is not necessarily produce gout. Uric acid solution injected into specific joint or blood does not lead to gouty arthritis. Come on. What is they did study? They injected the uric acid alone in the joint. It never produced any gouty feature. However, injection of extract from tophi produces the inflammation. Tophi contain what? Monosodium urate. So that's why monosodium urate is the best answer. Uric acid is not the answer. Calcium pyrophosphate lead to pseudogout, the point we discussed in the previous question, no need to discuss again. Calcium hydroxyapatite, again we discussed, it is lead to Milwaukee shoulder, and that involves the shoulder joint. Okay. So thank you very much. God bless all of you.